health. We're going to change topic a little bit and talk about MRI catheterization, a different imaging modality altogether, and how that can help us in the future cath lab.
Good morning. I'm going to talk about how MRI catheterization is now possible in patients, and much of this work is that of our moderator, Dr. Rogers. NIH and Siemens have a collaborative research and development agreement for this kind of work. So you all know that MRI is information rich. It shows soft tissue. Compare these two images. This X-ray angiogram has a 1,000 pixel matrix at 15 frames a second, and real-time MRI has a much smaller pixel matrix at a much smaller frame rate. But these are actually the same thing, and by virtue of being able to see soft tissue, I assert there's actually more information in that smaller pixel matrix than in conventional X-ray. This comes at the expense of catheter and logistical complexity that I think can be justified if it's going to enable us to do new procedures and not just reduce radiation exposure to our pediatrics patients. So we've adopted MRI catheterization in our patients. It was first done in London by Reza Razavi. But we've now made it a routine in our lab. This is an example of our first patient where a balloon catheter is navigated under real-time MRI, first from the cava into the right atrium, now from the right ventricle into the pulmonary artery, and then selectively into each branch pulmonary artery. We're able to do, in just a few minutes, a comprehensive right heart catheterization using off-the-shelf catheter tools. And by combining flow and pressure in a variety of clinical subsets, we're able to get useful clinical information. NIH installed a similar laboratory to do largely the same thing at our neighboring pediatrics facility. This is Kanishka Ratnayaka and Elena Grant. They've navigated into the superior vena cava. Now you see in the right ventricle. Now you'll see the catheter navigate into the pulmonary artery, and it's just as boring under MRI as it is under X-ray, except there's no cost of additional imaging. There is zero radiation involved, and we can measure function and flow far more accurately than under X-ray. So it's nice to see the soft tissue as you work. I'll make the point in the next slide that flow is far more accurate using MRI than using thermal-dilution or FIC techniques. And there's a versatility, as you know, of techniques to image the heart that can be quite valuable in the managing of your patients in a single study. So thermal-dilution flow is intrinsically inaccurate, especially in tricuspid regurgitation or low cardiac output states, the patients in whom you most need to apply it. FIC flow also is intrinsically inaccurate because it relies on assumptions about myocardial oxygen consumption and also about unmeasured shunt through the coronary veins. Flow using FIC is almost useless in exercise or provocation states. By comparison, MRI flow is extremely reproducible and accurate, plus or minus about 10%. We've reduced this to an acceptable clinical workflow. In the course of about a half an hour, we're able to measure cardiac function, measure flow, measure measure pressures, and then conduct some kind of provocation, be it exercise or pharmacologic, to combine MRI and catheterization in a single session. While you're at it, we're able to get a great deal of additional information in a routine evaluation for pulmonary hypertension. By just taking 30 seconds and a cc of MRI contrast agent, we're able to get a screen for chronic thromboembolic pulmonary hypertension, as in this patient. If you're having trouble navigating the catheters, it's nice to know why, because you can see the chambers that you're navigating through. If there's a structural defect like this anomalous pulmonary vein, it's very handy to see that structural defect while you work. And I'll point out that at the NIH Clinical Center, if you're referred for right heart catheterization, that's going to be done routinely, not as a research protocol, but as a clinical standard under MRI. So you can do this. Here's some stuff we're working on in the short term, where, as I kind of hinted, we're starting to do exercise catheterization under MRI, which is quite handy and not too difficult. We have new techniques to measure flow on a beat-by-beat basis, so we'll be able to get high-resolution analysis after a variety of changing hemodynamic conditions in the evaluation of pulmonary hypertension, in the evaluation of heart failure with preserved ejection fraction, and so on. You don't need too much in order to do this. You need an MRI scanner. It's not clear to me that you need an adjoining X-ray scanner like we have in my lab, but you probably do need some special equipment. In particular, you need an audio communications system because it's an acoustically hostile environment to work in the scanner. It's really noisy. You need some way to connect your hemodynamic recording system, and there are a variety of solutions I mentioned here about ways to connect your Census or MacLab system to operate under MRI. We are able to connect a few inexpensive LCD projectors that cost just a few $100s so that we can watch as we work inside the lab. And every MRI systems vendor will provide you, under the right circumstances, a system easily to control the MRI scans in real time to allow you to perform these procedures. At NIH, we've been conducting a series of hands-on training courses where we teach you how to equip an interventional MRI suite, and we also allow all students to perform MRI catheterization on animals. In fact, we have one coming up next month. If anybody's interested, let us know. And we've now trained over 24 sites, so we can expect a bunch of sites to start adopting this and bring it into clinical care in the next few years. Let me show you a few promising applications that interest us. One is MRI myocardial biopsy. I'm sure most people in the room have performed myocardial biopsy, and if you do it any way I do, you can't really see the heart. We pretty much close our eyes, hope for the best, and clamp down on the bioptome. This is work by Dr. Rogers. He's worked with the developers of a MRI myocardial biopsy forceps, where the forceps is conspicuous and you can see the target tissue and you can see the target pathology, and perform these procedures very easily. And he's in an experiment that he cooked up, he showed that the diagnostic yield of MRI biopsy is much higher than X-ray biopsy, even when you first glance at the MRI and perform the procedure under X-ray. Also work by Dr. Rogers is the approach of myocardial chemoablation under MRI. There isn't a lot of time to do justice to this topic, but you all know that radiofrequency ablation treatment of rhythm disorders is complicated by local necrosis caused by the RF ablation, but a surrounding zone of oedema, as Dr. Rogers pronounces it, where there is reversible conduction block, and patients, the physician may not recognize that the lesion is not fully ablated. In fact, that probably contributes a great deal to rhythm recurrence over time. There's no real good way using echo or even MRI to distinguish permanent necrosis from edema after RF ablation. So there's no good way to assure that the target tissue is dead. By contrast, using a system similar to the biopsy system you showed, Dr. Rogers is injecting caustic agents under real-time guidance. And I'll show you in the next slide, he's able to deliver his caustic agent either superficially or deep. He's able to achieve confluent lesions, and he is certain that these lesions are irreversibly necrotic. He's used a variety of agents, both ethanol and vinegar, and shown that vinegar is quite effective. And what's interesting is that if acetic acid spills over after these injections, it's diluted harmlessly because, as you know, it's a glucose breakdown agent. Here's his comparison of ethanol lesions with acetic acid lesions. The ethanol lesions are fairly heterogeneous and might not be well suited to the treatment of rhythm disorders. By contrast, the acetic acid lesions are homogeneous and carefully circumscribed. This, of course, is a rediscovery of observations made by radiologists decades ago. He made a model of the critical isthmus of ischemic ventricular tachycardia and ablated the isthmus under real-time MRI. And you see these beautiful results. He also was able to show, using a NAVEX system, the abolition of this critical isthmus. I'm sorry, I'm going to move on for lack of time. But MRI chemoablation is pretty interesting because it's probably the only technique I'm aware of where you're able immediately to depict irreversible necrosis. And stay tuned, because we'd like to apply this to the management of patient with rhythm disorders. One final application is cavopulmonary shunt. Dr. Kanishka Rayaka, a pediatric interventional cardiologist, really interested to navigate the space in between large blood vessels to achieve a connection between large blood vessels. This is a superior cavopulmonary shunt, otherwise known as a Glenn shunt, which is part of the stage repair of single ventricle physiology. Under MRI, he navigates from the SVC into the right pulmonary artery. Once he has a wire across, he delivers a purpose-built covered stent that has a fancy anastomosis functionality, and is able to accomplish a gorgeous Glenn shunt like you see here. This was published in JACC Intervention last year. We're working hard to make guide wires that feel just like the metallic guide wires that we use under X-ray. These should materialize soon. So to summarize, simple clinical MRI catheterization is a reality. It's become the clinical standard at NIH. We've done it in more than 130 patients and adults. Our neighboring children's hospital has done it in more than 50 children, and we're providing hands-on training for sites across the world. We have suitable clinical workflows that are pretty nice. I think it's good for your patients, probably good for your program, and easy for you to perform. So if you're interested to learn more about MRI catheterization, please contact us. Thanks for your attention.